So my presentation is unveiling the secrets of skin, the dermatologist quiz. I made this as a quiz challenge because so that it makes it as an interactive session. So without delay, I'm going to start my questions. So you can answer. The answers may be incorrect or correct, right? Right. So this is the first case. The 10-year-old child presented with an asymptomatic to mildly painful skin eruptions on the face for 1 week of duration. What do you think? Do you think it's the number one, sarcoidosis? Anyone think it's an inflammatory tinea? Okay. So what about the cutaneous leishmaniasis? Who else think Hansen's disease? Or anyone believes it's an allergic contact dermatitis? So what do you think? So the answer, Hansen's leprosy. Right? So you can see actually hyperpigmented to the brownish color, large plaques, mainly in the facial face. So this, because of the leprosy is quite common, and we are progressively increasing number of cases are identified day-to-day clinical practice. So that's why we are included this session, this slide. So as you will know, this actually the leprosy is a spectrum of disease, and one end is a tuberculous leprosy, and the other end is a lepromatous leprosy. And those who have in a good cell-mediated immunity, they have a less number of lesions that were tuberculous ball, and while those who have antibody response, they have the multi-system disorder that's called a lepromatous entity. So I have included some of the pictures so that you can understand some of these cases. So according to WHO classification, the leprosy, they categorize the postbacillary and the multibacillary. The number of lesions of less than 5 or the only one thickened palpable nerve with the negative slit skin smears, they categorize postbacillary, while it's more than 6 lesions and the 2 or more thickened lesions with the positive slit skin smears, they classify it according to the multibacillary. And this is actually the operational purposes. However, the readily classification that classifies according to the morphological classification, based on the morphology of the lesions, the tubercular leprosy, borderline tubercular, mid-borderline, and borderline lepromatous leprosy and lepromatous leprosy. In addition, they have indeterminate and pure neural leprosy. In pure neural leprosy, you can't see any visible skin manifestations, but they have underlying neural involvement. So I have included there's a tubercular leprosy ball, and so you can see there's a hypopigmented large patch in the right cheek region. And also you can appreciate the coppery color hypopigmented patch. And if you see these type of patch, actually it's mandatory to take the sensation for the impairment of sensation. But unfortunately, actually the facial innervation, there's a marked facial innervation, you can't get exact impairment of sensation in these cases. So then we discuss actually the borderline one, the borderline tubercular leprosy. Borderline tubercular leprosy, but you can see this is the same like actually hyperpigmented patch. And so you can see there's the amoeboid fashion invasion into the adjacent normal skin. And also that you can see the satellite lesion in the adjacent main lesion. So see the coppery color large plaque. See the large patch with the elevated border. So if you notice this type of anhydrous, actually a very dry patch, so always have a clinical suspicion about leprosy and test the sensation for impairment of any sensation. So, and this is also another case of actually border tubercular leprosy. So you can see the elevated thickened border with the central hypopigmentation. And also this is another case, right? You can see it's a hypopigmented patch in the this cheek lesion. And also this is actually, but not leprosy, this is actually Pityriasis alba. So, and this here also you can see multiple hypopigmented similar like patches in the chest of back of the chest. So these are it's like a Pityriasis versicolor. So this is actually nevus depigmentosus, the nevus, and also it's like an actinicus. And also this one you can see a multiple hypopigmented patches in the back. So this involvement is atopic dermatitis. So there are a lot of clinical mimickers, but it's important to test the sensation in these hyperpigmented patches. So then we move to the borderline leprosy. So because these, and here you can see erythematous borders with a typical well-defined border with inverted sauceriform appearance. It's called donut appearance. It's this, but so in this case also, so and here also these are borderline leprosy. So we move to the. So there are a lot of similars. It mimics like a borderline leprosy. Leprosy body. And see in this picture actually you can see annular scaly patch. So this is actually a tinea goporis, right? And also erythema annular centrifugum. And then here you can also see like a annular hypopigmented patch with the broad significant border, but this is granuloma annulare. And also you can appreciate that here is a multiple annular erythematous patches. So it's a subacute lupus erythematosus. And also this is a lupus vulgaris. So a lot of mimickers active, right? So it's a mainly a clinical suspicion. And also this is actually a case of mycosis fungoides. And so once we come to the borderline leprosy, so you can see multiple hypopigmented patches. And but unfortunately, these type of cases actually you can't get an impairment of sensation. And they move to the lepromatous pole. Actually, you can see a multibacillary pole. You can see a numerous number of leprobacilli here, and you see the typical leonine faces, and you can see the marked infiltration, induration of the skin, and also the loss of lateral eyebrow region, and also the collapse of nose, and the hyperpigmentation with the dryness of the skin. So this all together with the multi-system disorder is called the lepromatous leprosy. So there's another type of history leprosy. You can see there's a skin color to a brownish color of papules and nodules that are distributed in the face. Sometimes maybe a solitary lesion or sometimes it's a numerous lesions, right? And appreciate that the nodularity of the involvement of the earlobes. So in addition, I have mentioned just to see actually get an idea about how the type leprosy reactions. And this type 1 leper reactions is actually delayed type hypertrophy reactions. And so you can see the erythematous tender appearance of the plaque. And these lesions actually they have developed in the previously hypopigmented anesthetic patches. And they develop actually sudden onset. And see the involvement of the eyelid region. And while the type 2 leprosy is called erythema nodosum leprosum reactions, the vascular lesions. So you can see a tender nodules development and sometimes with the neurological involvement. So these are the just to be discussed. So the treatment modalities and the post-bacillary and the multibacillary depending on the age of the age. So then we move to the next case. So this is actually 7-year-old child presenting with an itchy skin eruptions on the body, including the hands and feet for 3 months. What is like diagnosis of this child? I believe it's a papulotic area. Who thinks actually the pompholics or this hydrotic type of eczema? Anybody believes the lupus erythematosus? What about scabies? Yes, correct. Yeah, it's actually a case of scabies, and you can see the mark, the involvement of the finger webs regions, right, and also the umbilical region. So it's a diagnosis, it's the scabies. And scabies, as you know, the human scabies is a very porotic dermatosis caused by infestations with the host-specific 8-legged mite-called Sarcoptes communis. It's a host-specific one. And the first time infestation, it usually takes 2 to 6 weeks before the host immune system to become sensitive to the mite or by its byproducts, resulting in the pruritus and cutaneous lesions. And typically, this intense pruritus is actually accentuated at night time and after hot bath. And the cutaneous lesions typically involve the interdigital webbing, as I shown you the earlier picture, right? So the interdigital involvement is typical, and in addition, they have the flexural aspect of the wrist, axillary areas, and both auricular area, wrist, and buttocks regions. In male, interestingly, you can see the penile and scrotal lesions. These are actually the skin color, erythematous papules, and nodules. That's quite common. While in females, the areola, nipples, and vulvar areas are commonly involved. And the pathognomonic sign is the burrow. That's it. If you see a burrow, and that's it. And the red in the tunnel that the female might create that while laying the eggs, especially at night time. That's why they get into pruritus. And acral vesicopustules can represent a clue to the diagnosis of scabies in infants. So here you can see the involvement of multiple fluidic erythematous papules and nodules. This is how Scabia varroa, so take mite. And this is the typical appearance of a varroa. If you see, that's it. That is the diagnosis, right? So the treatment is actually by 5% permethrin cream or lotion application, right? The overnight application and repeated in one week of duration. And the plural test can be evaluated by giving some antihistamines and emollients. And also sulfate ointment and oral albacate can also be used. So then move to the next case. It's actually asymptomatic hypopigmented eruptions on the body involving the buttocks mainly for 6 months duration. What do you think? Do you think it's a Pityriasis versicolor? Anybody think it's a tuberculous leprosy? What about vitiligo? Or the cutaneous T-cell lymphoma, or it's called the Mycosis fungoides. So the answer is cutaneous T-cell lymphoma, Mycosis fungoides, right? So just I included this the slide. So that you can see a hypopigmented patches, right? It almost looks like actually the leprosy, right? But check the sensation, that's important, right? And Mycosis fungoides is also, even though it's an uncommon entity, but we can encounter a significant number of cases day-to-day basis, right? It's also called a but what we see commonly is a hypopigmented variant, but it's actually a clinical entity that goes actually the go to the patch stage, and then you go to the plaque and tumor stage and the sessile stage. But the typical feature is actually that you can see the in hypopigmented patches that predominantly involve the double region. Pigmented patches, it involves the breast region and the buttocks regions and the upper inner aspect of the medial thigh and the arm. Then you can have a clinical clue about the mycosis fungoides, right? So we go to another case actually. So this is actually a 60-year-old gentleman presenting with an asymptomatic skin eruption on the back of the neck for 2 months duration. What do you think? Anyone believe this is lupus vulgar or cutaneous tuberculosis, cutaneous leishmaniasis, or cutaneous deposit of underlying malignancy? So the answer is cutaneous leishmaniasis. You can't believe actually that there's massive lesion involving in the nape of the neck, or the neck region, right? So you can see the large involvement with the indurated large plaque. So at the central ulceration, right? The lesion is asymptomatic unless it's an infected, right? So I have included these some slides to show you to get an understanding about the leishmaniasis, right? So this is a leishmaniasis, as you know, it's a commonly prevailing entity in this part of the country, right? And so this is a urolither. This is by Leprosy sand bite, and it's a great clinical mimic. So you can get actually initially the asymptomatic papule, but it progressively increasing to get an created from nodule, right? And also it may be presenting as like a plaque lesions, or sometimes actually the psoriasiform lesions, and sometimes abortive verrucous-like lesions, and some like mimic a basal cell carcinoma. You can see it's almost like a basal cell carcinoma in the typical site. So and also some of these are like an ulcer-like cells, right? And in addition, you may get the lesions here, but you can get a linear spread actually here, the lymphatic spread. So it's called the sport-like fashion of distribution of leishmaniasis. And this looks like actually a discoid like eczema, but this also is actually a leishmaniasis. So sometimes the involvement of these lesions in over the cartilage regions, then it becomes difficult to treat, right? So over the cartilage regions, that you can say that this is actually a Chickler or ulcer. So this actually involvement of the nasal alar region. So, and also if it's not treated actually, then it progresses to leading to severe mutating state. See how mutated the state is, right? And also it may equal mutated lesions. That's called chicular ulcer. So the espondia, like this espondia, so chicular, mucosal ulcers in the oral cavity. So it's actually clinical suspicion. If the lesions are asymptomatic and if you notice these lesions on the exposed body site, then you have a clinical clue, right? And sometimes patient may be in the endemic area like this part of the country, and sometimes the patient may not, and sometimes and may visit to the endemic area recently and acquired it. And also the most lesions they don't have, they are asymptomatic. They don't have pain and they are not itchy. And the presence of lesions, the lesions are last months, sometimes years, right, without they have noticed. And sometimes patient might have get their antibiotic without any response. And also, so also inquired, you can get a similar lesions in the adjacent household related, right? So and if you suspect any lesion, that is important to get skin smears, that's it for the skin smear. And if you see a skin smear with the gym sustain, you can see a Donovan bodies. If you see in the under light microscope, that's it. That you can come to conclusion, right? But if you not, then we have to go for a biopsy for the histopathology. And the treatment, the gold standard treatment modality is the sodium histogluconate. It's been available. Unfortunately, it is not available in all over the country. But so we are giving that to the interlesional metronidazole. But our heat therapy works very well. With the combination of the heat therapy, we have managed quite a significant number of cases with good response. And in addition, that we can use a liquid nitrogen cryotherapy for some resistant cases. So then we go to the next case. This is a painful eruption on the right upper limb for 1 day duration. What do you think? Anybody believe it's an allergic contact dermatitis or impetigo, phytophotodermatitis, that is plant contact dermatitis, or blister beetle dermatitis? Yes, correct. Yeah, it's a blister beetle dermatitis. You can appreciate that the lesions are in the mirror image lesions, mirror image, like a kissing lesions. So that's the point, right? The kissing lesion. It can be acquired in any body site, right? Meaning the flexural aspects are quite common. So the blister beetle dermatitis, right? So the blister beetle dermatitis also middle dermatitis, right? And these are insect actually. This is not by the insect bite, but by the crushing of the insect, right? The insects are of the family of Staphylidae in the order of Polyptera beetles, right? And it is due to the crushing of the beetles on the skin and causing the beetle to release a fluid called hemolymph. It's like a blood in ours, but they have hemolymph in their leg joints, which are called cathridine or the canthrid or pityriasis, which are this causes an irritant type of contact dermatitis. And it's characterized by superficial blisters, and the kissing or mirror image lesions can be seen when the blister comes in contact with the adjacent skin when bending of the arms and legs. And they heal without any complications within a few days of time. That's actually applications of topical antibiotics, the steroid creams and antihistamines will cure the condition. So we move to another interesting case. This is 25-year-old gentleman presented with an actually itchy skin eruption in the right face for 3 months. So, what do you think? Who thinks the allergic contact dermatitis to topical antibiotic application? Anybody believe it's a lupus vulgaris? Number 3, impetigo, or leprosy with type 1 reaction, or tinea incognito. It's quite difficult. But yes, it's a tinea incognito. That's correct. Yeah, because tinea is now actually very, very prevailing condition, but unfortunately, that can be actually seen in quite recalcitrant type of types, right? So, so the tinea corpore is the typical view is actually this you can see the hypo, a scaly patch with the elevated border, well-defined border. With the border is studded with the cyanic pustules, right? With the central clearance. This is a typical border. But this picture, the morphological aspect is totally disturbed by the applications of pure topical steroids. So that's called the tinea incognito or the steroid modified tinea, right? So you can't see the just application. If you suspect lesions of tinea, it's mandatory to treat by actually have a clinical suspicion, then treat with only the antifungal, right? Not with the pure topical steroids. If you treat it, then it's actually very, very disaster, and then it's very difficult to even the treatment treat. So you can see multiple erythematous patches but see the total disturbance. You can't see the exact morphology of this picture, right? So totally disturbed. So they are modified, right? They are exhibited that. So this you can't get actually you can access the morphology, right? So because actually it suppresses the inflammation, that's true, but the underlying fungus will grow, right? So that's because these are the medication, topical application, the enzyme like diclomine, enzyme, the promethazole creams and application, this worsen the condition, right? So the tinea, you should not apply pure topical steroid in these cases. So the tinea incognito has actually less elevated margins and less scaly and more pustular and more extensive and more irritable. And also you may see a secondary changes due to long-term use of topical steroids such as skin atrophy and telangiectasia and also purpura, right? So I have few slides mentioning because actually quite common disorder in this part of the country, in the whole of the country, right? And so the general disease in the possible. And also it is important to refrain from sharing clothes, towels, and other personal items including soaps. And washing hands with soap and water after the lesions and maintaining good personal hygiene is always advisable. And also the clinician should advise the patient to wash clothes using hot water and let them dry under direct sunlight. If it's not possible, ironing on clothes including undergarments should be done. And the patient clothing should be washed separately from the clothing from others. That's also important, right? And also the minimizing contact with the contact with minimizing contact with other family members is also important. And the patient must be advised to maintain the highest level of compliance with the treatment. That's important. Patient may take actually because of the high prices of the medication also that increase the barrier to the proper treatment. But the compliance of in view achieve the desired outcome, and they should continue treatment for required duration and should not use any preparation containing topical steroid for a quick release. Right? And once we move to the topical antifungals, what we are using nowadays, and in almost all clinical scenarios, the topical antifungals should be used as an adjunct treatment to the oral antifungals. It's mandatory, right? And for the neutropenia, for a single patch, topical applications may be used alone. And miconazole has antibacterial properties, especially against Staph aureus, and both miconazole and amorolfine, the colosaril, have some anti-inflammatory properties. And they may have advantages using topical if the lesions are inflamed. And the use of topical terbinafine may be considered in the management of tinea. However, this should be guided by the local resistant pattern of fungal to LMA. And the amorolfine is suitable alternative to azoles. And cyclopirax also can be used as effective treatment. And if it's recommended to use the topical antifungals of different class, if you use a different oral antifungal, use a different type of a topical application. If you use oral itraconazole, then apply topical terbinafine, right? So when you apply topical antifungal, and you should apply 2 centimeters beyond the active wedge, right? And also advising the patient to apply topical antifungal to extensive body areas may have a significant also financial burden, right? But hamper the continuation of oral antifungals by the patient for the prescribed period, right? And so once you move to the oral treatment, oral terbinafine, starting dose of 250 milligrams daily for 4 weeks. And where the inadequate response, decision may be taken to double the dose or increase the duration of the period, right? And in addition, you can use oral itraconazole, 200 daily or 100 2 grams a day for 4 to 6 weeks. And patient should be reviewed in 4 weeks time to for the improvement of the condition. Oh, and also aggregate and the liver function test done in the 4 weeks of time to see how they are, right? And it's preferable to continue oral antifungals more than 2 to 4 weeks past the clinical key of the condition. And also you can use oral fluconazole, however, it's just a global resistant to the medication, but you can use oral fluconazole daily basis for until the clinical cure. And also, however, oral fluconazole weekly 150 pulse dose is strongly discouraged, right? So in special situations, the pregnancy and the pregnancy lactation, pregnancy you can use terbinafine, right? In lactation, in topical steroid applications, and also the terbinafine resufalin should not be used in the lactation, but fluconazole is a safer drug rather than itraconazole, right? And the liver disease actually the topical application can be safely used. Fluconazole dose adjustment can be used, and with the monitoring of liver transaminase. But terbinafine resufalin should not be used in liver disease. Renal dysfunction, fluconazole is safe, and cardiac disease, fluconazole is safe, and elderly patient, topical applications, and dermatology is area. So then we move to the next case. This is sudden onset of asymptomatic skin eruption on the body for 1 week duration. So toxic epidermal necrolysis, pemphigus vulgaris, severe allergic contact dermatitis of bullous pemphigoid. The pemphigus vulgaris, right? Because actually you can see here because I have used this picture actually just to identify the condition and just to refer to the dermatological clinics, right? So you can see this is the involvement of cutaneous as well as mucous membranes, right? If you notice this thing, actually you can have a high index of suspicion about pemphigus vulgaris, right? And you can see the flaccid picture. This is very flaccid, not dense, right? The flaccid nature, right? So this is diagnosis of pemphigus vulgaris. Just as you see, this is actually the basement membrane zone and above the basement membrane zone. If the split occurs above the basement membrane zone, then actually the blisters are very flaccid. But however, if the split occurs below the basement membrane zone, you can see the blister wall is thick. So then the blister wall is thick and then there's a dense blisters, right? Yeah, the split occurs in the upper level because the autoantibody is one of the autoantibody disorders, right? Autoimmune disorder attacking the cell adhesion molecules here, right? So there's a split occurs in the above the basement membrane zone. That's why they get actually very flaccid blisters. So we move to the next case actually. This 60-year-old lady presented with asymptomatic to itchy skin manifestation for 3 weeks duration. So what do you think? Is it a toxic epidermal necrolysis? Is it acne and acute irritant contact dermatitis or dermatitis herpetiformis or bullous pemphigoid? Yes, correct. Yeah, bullous pemphigoid. It's a case of bullous. It's a case of bullous pemphigoid. So that I've included this picture. This is actually the tense blister, tense in nature. So here the split occurs below the basement membrane. So that's why you get actually the very tense blister. And in this condition, actually the itching, the pruritus may precede the development of blisters. So if you know that these type of cases, actually better to refer dermatological opinion. So the bullous pemphigoid, so you can appreciate the nature of the blisters. So the management is actually with the steroids. So then we move to the next case. The mild disease eruption on the body for 1 week duration. What is diagnosis? Is it a Pityriasis versicolor? Tinea propolis? Or lichen planus? Or Pityriasis rosea? Or allergic reaction to medication? Yes. Pityriasis rosea is commonly encountered entity in this card, right? So you can see the oval shape, right? Oval. And also these are almost incolored to hypopigmented, right? Small macules and patches, right? And these lesions, oval lesions run along in the skin lines. In the abdomen, it's like an inverted Christmas tree pattern here. In the back of the tree, actually back side, you can see the Christmas tree pattern, right? So Pityriasis is a common condition, and most cases occur in the young, healthy individuals and peak incidence in adolescents. And human herpes virus 6 and 7 suggested the cause as a condition, right? And the herald patch, this is a herald patch, the large patch, herald the onset, initiate the onset of the disease. And mild erythematous patch, in which the small scales are centered in and larger trailing collarette of scale seen in the tree edge pointed towards here. You can see the collarette of scale. The scales are pointing towards the lesion, inner aspect. That's a typical feature. That's called collarette of scale. This is a herald patch. This is a mother patch, right? Large patch. So, the 5% of patients experience mild prodrome. They may have a mild fever, and lesions are usually round oval shape, and they are runs along the long axis, the Langer lines, right? And face, palms, and soles are usually spared. And eruption they last 6 to 8 weeks for a proper spontaneous resolution, and 25 also not provided. But however, they have some atypical presentations such as inverse type. You can see there's an inverse type of Pityriasis, and some of the lesions are pustular, and some are here. You can see a target lesions. target lesions, right? So the usual topical applications of steroid will cure the condition with antihistamines, right?
Then it's between the
No. No, nothing. So what's your diagnosis in this condition? It's a spot diagnosis. Allergic contact dermatitis, impetigo, acute eczema, herpes simplex. Yeah, herpes simplex. Yeah, you can see the small vesicles involved and leading to crusting, right? So I have included this picture here. So you can see that there are multiple group vesicles. That's a typical picture. Group vesicles, and in the erythematous background, right? And then once they get together, they one has to form large sheets, and then they erode, right? So that's a typical feature. So herpes simplex infection. So what is this diagnosis of this condition? Acute eczema, Rett syndrome, acute zinc deficiency, eczema herpetica. Is eczema herpetica. Yeah, you can see that here. The vesicles actually erode, leading to typical scallop border. The edges are very prominent. The scallop borders give a typical impression about the HSV infection. This is a child with actually atopic dermatitis and secondary infected with the bacterial Staph aureus as well as the HSV infection. So it's called eczema herpeticum. So in this case, the acyclovir is mandatory, right? Otherwise, it will not be. So then this is another interesting case. What's the most likely diagnosis of this condition? You think it's an allergic contact dermatitis? Or it's an irritant contact dermatitis? Or is it erysipelas? Erysipelas means superficial type of cellulitis. Or herpes zoster ophthalmicus. Yes, correct. Yeah, it's a herpes zoster ophthalmicus that you clearly see some vesicle, it's an asymmetrical lesion. By look of it, there's asymmetric lesion, and you can see the multiple group of vesicles involved in the right side of the face with the swollen right upper lip. And here, the tip of the nose also involved. In this case, it's important to remember that the ciliary branch of the trigeminal nerve is supplied to the corneal division, right? So if you see this picture, it's mandatory to get an ophthalmological opinion because it leads to the corneal ulceration. If you delay the treatment or get an eye opinion, so it may lead to the total blindness of the condition, right? So need to get the treatment parallel with the get the eye opinion, right? To save the eyes, right? By in this case, actually need the oral acyclovir or sometimes IV acyclovir or acyclovir 800 milligram 5 times a day for even 7 days to 14 days. So I have included this picture also. The 6-month-old child presenting with an asymptomatic erythematous eruption on the left lower lip for 2 months duration. Anybody think the mucosal involved due to leishmaniasis or pyogenic granuloma, hemangioma, or abscess with ulceration? Sometimes we may encounter this entity. It's called hemangioma, right? Hemangioma. So I have included some of the pictures actually, right? This usually you get hemangioma, right? So typically in after 2 months of age, it's actually erythematous vascular or sometimes nodule, right? If remember, if you see these type of lesions, actually better early refer to the dermatological view, right? Because in this lesion, if it's this lesion located above the eye region, it involves definitely vision, right? And also with the hearing defects, right? And also with the lip involvement, it leads to the feeling problems. And the genital regions, they are the sites where the trauma, right? So it's, and in this case, hemangiomas, they have initially the more proliferative phase. It lasts for a few months and then come to the plateau phase and then regression phase. And it's important to get the treatment at the proliferative phase by a oral propranolol treatment. If you delay treatment, there's no use. So then we go to the next case. The 30-year-old child presented with mild fever, presented with this eruption for 2 days. What's the diagnosis? Yes, that's quite obvious. You can see a lot of cases in here, and foot and mouth disease. And typically, here you can see the oval shape. In chickenpox, you can see the round shape, right? Here, they are oval shape vesicles and with the erythematous halo. That's give a clue, right? And also you can see the palm plant involvement with the oral mucosal lesions, right? And hand foot and mouth disease, as you all know, is caused by enteroviruses, Coxsackie A16, A6, and 71. And this is a vesicular eruption and palm sole in conjunction with the erosive stomatitis. And the dorsal of the hand and feet may be inward, as well as buttocks region and perineum. And the oral lesions are most common in the tongue, buccal mucosa, palate, uvula, and anterior pilar. And the onychomatosis, this is a typical feature, right? And with actually the any stressful event, actually any febrile episode, you can get a temporary arrest of the nail matrix and lead into arrest of the nail growth. That's why you may get the Bullous lines, right? So it's quite common scenario, right? So the Bullous line, right? And also this is called there's a shedding of the nail plate. You can see there's a line with the shedding of the nail plate. So onychomatosis, right? That's we commonly see in after a febrile episode. So the zinc, it's a symptomatic treatment with the zinc supplements. So next one, the 8 month of baby present with the itchy rash on the body, including the face. So what do you think? Is it separate dermatitis, atopic dermatitis, infant acne, or allergic contact dermatitis? It's actually a atopic dermatitis, right? So atopic dermatitis is called common quality, right? And I have included a picture here. So this its main involvement actually the infant with the 2 months age, right? And here the typical appearance of the whole face with the centrofacial, mild centrofacial sparing, right? Cheeks, forehead, and initially the facial areas, and with evolution they have evolved extensions as well, right? And in addition, this association with actually the atopic dermatitis is associated with some keratosis pilaris, hyperlinearity of the palms, the ichthyosis vulgaris, the dry fish scale-like scales, and also once they have scratched the skin, actually they may create another fold actually, interorbital Danny Morgan fold, right? So these are some associated features. So we move to the next case. The 7-year-old child presented with the skin color eruptions on the face for 2 week duration. What do you think? Yes, very good. Yeah, it's called molluscum contagiosum, right? So I have included the picture, right? So typically you can see the clear skin color to pearly papules with the central umbiligation. You can see it's an indent in the center, pearly papules with the clear indentation, umbiligation, right? So if you noted this one, this is a molluscum contagiosum. But in some immunocompromised patient, you may get some atypical presentations, right? So the treatment is liquid biotherapy, tribolotic acid applications, right? Or sometimes manual expression of the lesion. And then the diagnosis of this condition. What do you think? Anyone be it's acute atopic dermatitis or zinc deficiency, seborrheic dermatitis, or infantile infectious psoriasis? This is entity is called seborrheic dermatitis, right? So you can see here actually the involvement of seborrheic areas and main the fractional aspect of the body, right? Fractional areas. So the seborrheic dermatitis is a chronic eczema, typically gets regions with a high serum production, right? With a large body folds. Malassezia purpur plays a role, and the seborrheic dermatitis is actually most often seen in the limited extent, but sometimes generalized and erythrodermic forms are can. You can see the previous picture, erythrodermic forms, right? And usually begins about 1 week after birth and may persist for several months. And initially, you can see the greasy scales at the vertex. And here, the cradle cap. You may have noticed actually there's a cradle cap, the thick actual plaque-like lesion in the frontal aspect of the scalp. So it's a cradle cap. And also the see the face, the eyebrow region, and also the post-auricular regions, and this one apial folds. So these are the common sites of involvement, right? And the lesions may appear in the retroauricular region, behind the ear region, neck, trunk, proximal extremities, right? So the treatment is actually the topical applications of miconazole and some antifungal soaps, shampoos, right? And the emollients applications, right? And the next case, the 60-year-old gentleman presenting with the itchy rash on the back of the back for 2 months duration. What do you think? Hmm? Yes, yes. So if you see this lesion actually, right? if you know that this type of bacterium, the surface is trapped in the eczematous patch. So the diagnosis is now mycosis, right? So it's acutely larval mycosis by dogs and cat hookworms, right? And so you can appreciate the surface tract here, right? So it may be actually bullous type. But even though it's a bullous appearance, you can see, appreciate that the lesions are in the surface tract, right? So it starting with one entity and they end with some product, right? The treatment is oral albendazole, not the nibendazole, albendazole, 10 to 50 milligram per kg day for 3 to 5 days, right? And sometimes we use the liquid therapy to the advancing age to freeze the lesion. So this is another case. What's your diagnosis at this time? Discoid eczema or alligator pigmentosa and this is impetigo. Impetigo, yes, correct, yeah. So you can see there's multiple of the lesions with typical, you can see the honey color nature. If you identify typical is actually these areas, the honey color, if you know honey color nature, then it gives the impression about the impetigo. So the impetigo is a common contagious disease, and it's most actually the bullous types and non-bullous types, right? And bullous type, the bullous type, on the other hand, you can see the multiple flaccid blisters with the half-feet puff. So site content is quite extensive, right? So this is bullous impetigo due to Staphylococcus infection due to toxin secretion, right? So the need to treat with actual the systemic antibiotics, right? And neopracin applications and symptomatic shampoos. So this is another case. To a 75-year-old lady presented with asymptomatic eruption on the right for 2 years duration. So what do you think? Yes, very good. Yes, basal cell carcinoma, right? So you can see here typically, right? So basal cell carcinoma. So you can see the high pigmented rolled edges, right? And sometimes the pigmented eruptions, the plaque-like lesions, and typically these are really a pearly color rolled edges. And if you see clearly, so you can see the lines, the blood vessels, capillaries run above the shoulder regions, right? So the typical scenario, if you notice these type of, unfortunately these are local lesions, but in some of the cases they are metastasized in the squamous lesion. So it's important to identify these lesions because these are commonly seen in this part of the country because most are farmers and they are exposed to sunlight and UV exposure. So these are, I have seen a lot of cases with the basal cell carcinoma. So better get to the dermatology review for these type of cases. The complete excision will resolve the condition, right? So there's another case also on the left side for 5 months of duration. Anyone thinks is a pyoderma gangrenosum, venous ulcer, ecthyma gangrenosum, squamous cell carcinoma. Yes, it's a squamous cell carcinoma, correct answer, right? You can see it's actually the very unsightly actually ulcer in the typically scar area, right? So it's mandatory actually some chronic conditions such as hypertrophic lichen planus. One of the skin dermatosis you can see if you notice any atypical like ulcer formation in the edge, in the chronic lesion, if it's a burn lesion or any chronic lesions, if you see any asymmetrical body appearance of ulcer, so it's important to have a clinical suspicion about squamous cell carcinoma and get then for the for the biopsy to exclude the squamous cell carcinoma. So then this is my final case, right? So the 45-year farmer presented with asymptomatic eruption of the heat for 10 months duration. What do you think? Is it calondoia, trauma, spina pedis, infected viral, both for malignant melanoma? Yes, very good. Yes, malignant melanoma, right? So you can see here the asymmetry of the lesion and the color variability, right? And the ulcer, right? So I included this picture, right? So you can see that asymmetry and the borderline irregularity and the color variability and also the diameter more than 6 millimeters and the evolution sometimes maybe goes ulcer and pain, right? So and this is actually subbungal melanoma. So you can see the involvement of the proximal nail fold. That's called Hutchison sign. So if you see any lesion, see it's an asymmetric lesion, an ulcer, and the pigment color variation. So we have also, even though it's uncommon in our part of the country, but we have seen quite number of cases. So if you have a clinical suspicion about these lesions, we take it early, urgent, regular to the unit. So then I am winding my presentation today. Right. Thank you so much for listening.